Okay, super. So we're going to do the Ask the Doctor session. This is actually, when we look at surveys from prior forums, this is everyone's favorite. And we have many questions that have already been given to us, but let's start off by inviting our faculty up here. We have Steve Ansell already. We've got Christian Buske. Dr. Jorge Castillo, where are you? Come on up. Let's give them all a round of applause. Yes. All right. And all the way from the United Kingdom, we've got Shirley D'Sa. Welcome to Shirley. We have Dr. Peter Forsberg from the Blood Cancer Institute in Denver. Welcome, Peter. And Yazeed Sawalha from here, the local favorite from Columbus, Ohio, at Ohio State University, the James Cancer Center. Welcome, welcome, welcome. Now notice everybody gets a chair except me, but we're gonna make this very efficient. Now, the first thing we always like to say is what answers you'll hear today, please don't take them as specific recommendations for therapy. They're really provided for general knowledge because none of the doctors up here really have a very intimate understanding of a particular patient's case. So we just appreciate your being able to understand that, and obviously discuss what you learned today with your individual doctor in terms of formulating, a plan going forward. And if we don't get to all the questions, it's because you submitted so many good questions. So for this reason, we'll do our best to get through. So let's get going here because Paul also has me on a timer here. So let's get going here because so many good questions. All right, we're going to start off with this one. How do mutation results influence your decisions? And Jorge, do you want to start off on this one?
You have yours.
I guess I have no choice. So I think from my perspective, mutations can be helpful in two different aspects, actually more than one. I think for diagnostic purposes, we have some mutation testing that are very important. Then when we select treatments, I think mutations are also important, and I'll just dig a little deeper on that a little bit later. And then to predict as well how well the patients or how fast the patients will respond or how long the patients will respond will be based also on mutations too. So for diagnostic purposes, I think MYD88 has established itself as the diagnostic marker, mutational marker for Waldenstroms macroglobulinemia. And as you mentioned during your presentation, CXCR4 mutations, even though we see it in about a third of patients, maybe 40% of patients with Waldenstroms, when somebody has a mutation in CXCR4, pretty much there's no other diagnosis that I consider in somebody who has a CXCR4 mutation. I think it's very specific for Waldenstroms. When we are about to select therapies, I still use MYD88 to think about some types of BTK inhibitors in terms of how to use them, as well as CXCR4. And now we have heard a lot about TP53 and deletion 17p, and I think that also plays a bit of a role on choosing a treatment over another. I think I want to be clear, and I would like to see what the rest of the board thinks here. I don't think a mutational testing being positive or negative actually nullifies one treatment or makes it totally ineligible for a specific treatment, but I think it favors a treatment over another treatment, and I think that's the way I tend to look into that. And obviously, once I decide what treatment is best for the patient, there are some mutations that can tell me, for example, CXCR4 mutation patients might take a little bit longer to respond to BTK inhibitors compared to patients without CXCR4 mutations. So it will work, but it will take a little bit longer, for example. So those are the three major mutations that I tend to check. And there's a new mutation in BTK now in patients who are on BTK inhibitors who might develop these mutations. And that can also help me in terms of selecting what the next treatment might be.
Yeah, I want to come back to the BTK mutation question. So you're saying MYD88, CXCR4, TP53, those are all in sort of your testing. So Christian, in Europe, you gave us a slightly different thinking around TP53. In fact, if I remember correctly, you wouldn't recommend it at this point in time. And I'm just wondering, what your feelings are about TP53.
Yeah, so I think we have a little bit to discriminate between daily clinical routine which is really a different world from what, let's say, we are doing in clinical trials. So in clinical trials or academic centers, we would always encourage to determine TP53 alterations because we have to learn, and otherwise we do not learn. So I think it's a must in this setting. So separate from this, we have in Germany 150 private practices, many small community hospitals. There is cost pressure. And of course, you have always to see whether these TP53 mutations today really give you a black and white response, how to adapt treatment in a patient. And this is, I think, still a moving field. And this is what we discussed very intensively in Athens. So meaning, yes, we would encourage, because we have to learn, but we would not say it's absolutely obligatory, because the patient's treatment will be definitely compromised when we do not know about the TP53 alterations. We have other examples where we know for much longer TP53, the importance of TP53 mutation. This is mantle cell lymphoma. But still, it's not obligatory outside of clinical trials in routine practice to determine TP53, because we still do not adapt treatment in mantle cell lymphoma with TP53 mutations. We have other diseases such as CLL. It's obligatory because it has a clear-cut impact on treatment decisions.
Shirley, do you want to also address this question?
I think my take is, I share Christian's view that we need to learn more and more about the influence of these different mutations. But what I say to my patients is that the information we have is at a sort of population level. So if I have a patient sitting in front of me, I cannot for sure say that because you have X, Y, and Z mutation, this is what's going to happen to you. So I think in general, we go along a path of treatment that we know should make sense. And the other thing I want to mention briefly is that the way you interrogate the disease and its microenvironment has an influence on the significance of these mutations. So the sensitivity of tests varies, and TP53 can be found both in the lymphoma cells but also in the non-lymphoma cells. So I think methodology is something that we need to work on, and so I think people shouldn't be overly twisted into the whole mutational thing. I think it's important, but more, I think, to examine and explore, and the future will tell us more, I think.
Steve, at the Mayo, how do you feel about TP53? Is it a test that you normally get, and do you reassess it with, after patients have been treated and come back again, perhaps for, additional therapy?
So I think the most important thing is to remember that never do a test unless you know what you're going to do with the result. And you've heard a little bit about the ambiguity of the results. So there are two reasons to do it. The one is to choose and select treatment. And I don't think in Waldenstroms we have really robust treatment decision-making around, for example, TP53. Your group's published more around CXCR4, which I think is being helpful. And there is some data to say you might do better with a BTK inhibitor, for example, than a chemotherapy if you have this TP53 mutation, because that's the quality control on the cell. And if the cell's quality control is absent, then it doesn't really care about what you're doing when you damage with chemotherapy. The other thing also just to think about is, and this is probably where, again, do you want to know, most of these mutations, the group does a little worse. So the whole idea is, do you want to know that? Do you want to have to down your expectations? So in our practice, to answer the question directly, we tend not to do that out of routine, in routine practice. We only do it in clinical trials.
Yeah. Peter?
Yeah, I might zig a little bit from the rest of the group. I think it depends on the clinical circumstance. So certainly, I think we're mostly talking about patients with newly diagnosed WM, where we're profiling their genetic landscape. And in that context, we're really trying to differentiate between something like BR and a BTK inhibitor. And in that setting, I do think P53 derangement, should be informative to my mind, just because we have enough accumulated evidence, not just in WM, but across other blood cancers, that patients who have abnormalities of that cell sort of regulatory pathway don't do as well with chemotherapy-based approaches. And when you're picking between two really effective paths, I think it can be something that helps. Again, kind of like Jorge said, it doesn't take any option out of the mix, but when we're trying to decide between good alternatives, I think it is informative between which makes the most sense for any individual patient potentially.
And Yazeed, how does Ohio feel about
so we
TP53 testing?
Yeah, so we have a panel that we check for patients with Waldenstroms, and that panel has the MYD88, which we want to check in all patients with Waldenstroms, but also the CXCR4 and the TP53. So I don't have to check for TP53 just because I want to. It's part of the panel, and I will have the results on almost all patients with Waldenstroms who had their biopsies done at OSU. I think I agree overall with the consensus here that the TP53 doesn't necessarily say that you have to do one treatment over the other, but it might make me favor more BTKI rather than chemotherapy, although we kind of have to acknowledge that this is still an area that we're learning about and we still need to do more research about it. It could be that in the future we have more kind of strict guidelines to say if you have TP53 you should do this or shouldn't do that, like we have in other types of lymphomas. I don't think we're there yet, but I hopefully with more research and more data we can. The other thing I would say, we always encourage clinical trials, but if you have this TP53 mutation, I think we kind of should think twice again, because this is would be a great option for these patients, because on average in general they're less likely to respond to the treatments we currently have.
We could probably spend 1.5 hours here on TP53, but to tell you, it really is a very important topic these days. Not only what you do with this information, as I think Steve very nicely alluded, we are starting to see some therapies that may be tailored around TP53 mutated patients, like loncastuximab, cellular therapies, but also the way we test for TP53 is important, because you can find these mutations even outside of the Waldenstroms clone in many patients, and in fact, that may also be very, very significant as we're learning. But we're going to hear more about this, I'm sure, in Palm Springs when we have the international workshop, so we will move on because we have a lot of other questions. This is a really good one. It's a perennial question. If you personally had newly symptomatic Waldenstroms today, what treatment would you choose and why? So, Peter, let's start with, let's see. Yeah.
Give me the easy one.
Yeah.
It's interesting. I've thought that a lot. With us, we're always on one side of the table having that conversation as we sort of lay out the pros and cons of these treatments and help people to make a decision. And I guess I can't help but think that my answer might be influenced by who I am. I think that's what it always should be. When we're helping folks to make this decision, the right decision takes into context who they are, what their situation is, what their preferences might be around a lot of things. What I would be if I were diagnosed today as a relatively young WM patient, and I do think in that context, it would probably influence me towards preferring a BTK inhibitor as my frontline therapy. Yes, I'd be potentially committing to taking, a pill or, twice a day pills, depending on how we structure it, for the next, ideally, like 40 years if all goes well. But I do. There is, some of the things that are rare but occasional risks with chemoimmunotherapy, like, secondary malignancy risk, things like that are things I might be pretty, worried about given my age. Whereas, I think that might be pretty different for somebody who's, in their 60s or early 70s. So I think some of those, personal factors would weigh in just how they would for any of our patients who are making that decision.
So I didn't hear which therapy you'd pick.
I picked zanubrutinib. I'll take zanubrutinib.
Okay, super. All right, the UK approach. Shirley, you're in the UK. How would you answer this question?
I would opt for our chemo. Time-limited treatment, tried and tested, not free from potential problems in the future. I would prefer DRC to Arbenda. I think Benda is very, very suppressive in many ways. If I needed Benda, I would try and reduce the number of cycles. And I would keep the BTKs in reserve for the future, because I'm hoping in time that we will be able to have them in a time-limited fashion when they are combined with other agents.
Steve?
So you made such a good point about it all depends where you are in your life journey. So as you can tell, my journey's gone a little further down the road. So my miles are kind of, I'm stacking up miles on this here vehicle. I would say I'm a big fan of immunotherapy, so I'm very excited about the future of that. But for me, the most important thing is what's going to impact my life the least and have the fewest long-term consequences. So I would take bendamustine and Rituxan, and I would just take 4 cycles. Again, why would I do that? Because it has high response rates, it's time limited, I can get back to my life. I do recognize that there may be some future risks, but I have less future. So that, that matters less to me, And immunotherapy, while I'm a fan, that's going to impact my immune system, and I might need to be on IVIG replacement for a long time, and I'm not excited about that. So I'm looking for what's going to give me maximum bang for the buck with the fewest potential side effects, and recognize that my timeline is shorter.
Steve, before you pass the mic on, I have to take issue.
I got out of this one.
It's interesting because they often ask folks, what would you do? And, and the answer would be around if you were dealing with a young patient as opposed to an old patient. And as oncologists get older, younger looks younger, right? So if you were 40-year-old Steve Ansell now, beginning your career, your robust career at the Mayo, would you answer this question differently?
So that's a good question. And so, again, if I look back and say, what do I value? I'm trying hard not to have something impact my life every day. So I'm, again, a fan of time-limited therapy. You made a great point. Could I be compromising and giving myself more risk because I'm going to potentially have more cancer issues from drugs like bendamustine? True, but do remember, just having Waldenstroms makes me at risk for other cancers because my immune surveillance is a little bit off. So I think my answer is still the same. What I'm hoping, though, is in the not very distant future, we have immunotherapies where I can just get 8 weeks, 6 weeks of a bispecific antibody and fix my problem for the long term. Now I'm super excited, but we're not quite there yet. You made some nice points this morning to say that's close, but 40, when I was 40, that was not an option at all. Back in those days, we were doing nasty stuff, and I wouldn't have gone for that.
Okay. Christian.
Yeah, I think first what is important to state also for our patients, it's really a situation of luxury. So there is no really wrong decision when you decide between a BTK inhibitor or our chemo. So they're both great options we have. I think that's very important to say. So I think we are more or less the same age. I guess, Steve, you will be younger than me, but so I would probably also go for our chemo, DRC. I quite bendamustine. It's great. It's a German drug, and but I tell you, Benda has also its certain characteristics. So I have quite a lot of respect for bendamustine, and we talked about the secondary neoplasias, and there are very good data, much more larger data in follicular lymphoma, for instance, and they show that this risk of secondary malignancies really depends also on the kind of chemo you got. And DRC is actually great because the risk will be probably lower than with bendamustine. And we just, we just presented in Athens our mature data from the ECWM1 study. So the patients got DRC, treatment naive, and your time to next treatment approaches nearly 70 months. and your overall survival after 5 years is 90%, and the survival, or let's say a survival related to lymphoma death, the survival is 96, 97% after 5 years. So you have really excellent disease control. So probably I would go for this, but as said, there is no wrong decision in that sense.
Okay, good point. Jorge, what would you do?
Yeah, so knowing what I know, doing this for the last 13 years, am I a little younger than you are? Probably a little older than you are. So I think if I could participate in a trial that will give me a non-chemotherapy exposure for a limited amount of time, I will jump on it immediately. That's what I would do. If the EPCO-ZANU study will be open, I think that would be my first choice. And I would not have any problems participating in the PROVEN study, which is the pirtobrutinib plus rituximab. I think that I will go into that 2 years of treatment, no chemo. That will be my initial choice. If there's no trial available, I think I will opt for a BTK inhibitor. I'm just, based on what I'm seeing, I'm just concerned about the potential risks of chemoimmunotherapy exposure, specifically the secondary malignancies, the myeloid malignancies, even though it's very rare, and just the impact of the immune system and the T cell function in the future. So seeing what I see coming up, that's probably what. And again, none of these will be totally, one option or the other, but I would do clinical trial. That would be my favorite option. BTK inhibitor, probably the second, and then chemoimmunotherapy.
Okay, fantastic. Good answer. And Yazeed?
Yeah, I agree. I don't think there's a wrong answer here. If my oncologist asks me in clinic, I'm going to say, let me think about it over the weekend and get back to you. I would just really take my time. I do have a toddler who's going to start going to daycare on next week, so probably not gonna go really well with Benda, so I might favor BTKI.
BTK inhibitor. Okay, so you see there's a consensus up here among our experts. But clinical trials, though, are very important. And if you had a choice between standard of care and a clinical trial, would you opt to be in a clinical trial? I mean, assuming it's a good clinical trial.
You know my answer.
I know Jorge's answer. Anyone think otherwise? No.
No, I think, because also not, of course, we have to advocate for clinical trials because otherwise we would not move forward. But what I'm also saying the patients is it's like a guarantee for high quality. Of course, not everywhere in Europe or probably also in the US, the quality level in this rare disease is the same. And when you participate in a clinical trial, you can be sure that you are treated at really state-of-the-art quality care. So it's like a quality stamp, we always say. The centers which are participating in such a trial, they are really quality centers. And this is sometimes also an important aspect when you are a patient in a more remote area.
Yeah. I would agree. I also personally would look for a clinical trial in the same situation as well. And it's nice now that we have, many options, even for clinical trials, as we saw in Europe at the ECWM meeting, as we heard also from Jorge about the WMNet. So we encourage you to consider clinical trials. Now, this question actually feeds right into this, and that is, what therapy or research area are you most excited about right now? And, can we start off maybe, Steve? Since you've identified yourself as the most seasoned among us here.
I think you heard already from this weekend, there's been a lot of progress over the years. And I think what's been exciting is the progress made in targeting the tumor cell and understanding its biology. But I think the thing that's happening now is what's been coming over maybe many decades is really harnessing the power of the immune system. So I think if I was to say what am I most excited about, is really how to get your immune system to target the tumor. Right now we're doing it in a very blunt way where we're just kind of grabbing the cell and spanking it and making it do stuff. If we could do that in a little more sophisticated way to maximize the benefit and minimize the toxicity. And then you've heard a lot about understanding all the negative effects around that activation. So you're trying to get the cell to do a good job, but it's got all of these bad influences around it that are trying to shut it down. So I think the opportunity is continuing to get the effector cell, the cell that does the damage, to do a good job, and all its buddies that are trying to shut it down to get out of the picture.
Okay. Now, again, sort of on this same theme, will it be possible to be treated with fixed duration inhibitors rather than forever prescriptions that we now have? And I know there's quite a few trials actually trying to address fixed duration therapy. Christian, maybe you can address this from the European perspective.
So, so I think for us, and I think on both sides of the Atlantic, it's a major goal to convert these targeted approaches immune therapies to fixed duration treatment, because I think this is what we want, what we all want. So you put it in a different way. So in essence, we had a leitmotif, and this was chronos, this was time, and leitmotif was giving time back to our patients. And fixed duration treatment means we give you treatment-free time. And I think this is so important for you to have time without treatment. And when you have non-fixed duration treatment, conceptually, you have no treatment-free time. And so this is why I think we have this vision and motivation. And I think the WMNet has wonderful trials testing this concept by combining two powerful drugs to be able to limit the duration of treatment. And also we in the European Consortium, we have a randomized trial which really compares DRC to a fixed duration chemo-free approach. And I think these kind of trials are so important to establish regimens which avoid chemo but nevertheless give you treatment-free time.
And Shirley, you sort of alluded, among your personal choice of therapy, that having a fixed duration of therapy was very important. Is there any particular fixed duration approach today that you're very excited about?
In terms of future therapies?
Or emerging therapies?
Emerging.
Yeah.
Yeah, I think the BTKI and BCL2 combinations, I think, sound extremely, they're promising because they have a great scientific rationale. We have evidence from other diseases that it works well. I think the bispecifics are also an area that I think is very, very exciting. I think there's work to be done in making it as safe as possible in terms of immune protection, because that's a problem for those that set of drugs. So I think those are that's where my gaze is focused in terms of hopefully seeing progress. Just in terms of other areas of interest, I think I've noticed a lot of inflammatory Waldenstroms patients in my practice, and I think that's an area that I would love to see greater developments in, because it has a big impact on people's lives. And I would love to see more studies into that. I know the French group are doing that to some extent. But the influence of chips, for example, these clonal hematopoiesis and the interactions within, this microenvironment, which makes WM very distinct from other forms of lymphoma. So slight digression to your question, but yeah.
So we're also seeing combinations with BTK inhibitors and chemoimmunotherapy. In China, we've seen, the Chinese zebra, we call it, zanubrutinib, bendamustine, and Rituxan. We've seen the Brahms study in Canada with acalabrutinib and bendamustine, Rituxan. And I believe in Boston, you also have the American zebra ongoing, I think fully enrolled at this point. Maybe, Jorge, you could comment on maybe these chemoimmunotherapy and BTK inhibitor combinations as a fixed approach.
Yeah, I mean, they're definitely an option, and it just makes sense to use the two most commonly used regimens. The reason we use these regimens is because they are safe and effective, and if we combine them in a reasonable manner, can we induce deeper responses that will last as long as they would otherwise, but without exposing patients to an indefinite duration therapy, right? And give the possibility of re-exposure to these therapies in the future, right? Because you didn't use chemotherapy all the way to all the cycles that you should have, and you didn't use BTK inhibitors all the way to failure. So you can always be re-exposed to these treatments in the future. So I think that's the rationale, clinical rationale to do something of this nature. Obviously, we don't have a lot of data on it yet. I mean, we know the acala bendamustine rituximab, the BROM study has shown very nice deep responses, are a proportion of deeper responses higher than expected for each of the separate treatments alone. So we're expecting the zebra, Chinese zebra, and the American zebra to show something similar as well. We will be, from the American zebra perspective, I think we'll be doing a data cutoff soon, so we can present some significant data later this year.
You know, often this question of indefinite duration versus fixed duration comes up, but you know, I'm often reminded of the fact that when we're dealing with high cholesterol, diabetes, you know, high blood pressure, we have no issue with being on indefinite therapy, even if it isn't, you know, curative. But Peter, when your patients come in, you know, how important is a fixed duration versus indefinite?
Yeah, I mean, I think you get at something very fundamental about it. You know, it's interesting. In the last talk, Jorge mentioned that we have worked recently to try to define what cure means in multiple myeloma, now that we are harnessing some of these immunotherapies. And one of the things we've considered to be a contingent characteristic of defining cure is not indefinite therapy. It is using finite duration of therapy with indefinite response. So I think if that's our priority and our goal, I do think, you know, finite therapy, is our way to try to accomplish that. That said, if we have a targeted therapy that's so refined and so effective that it becomes, you know, deeply non-toxic to take for an extended period of time, that penalty for indefinite therapy may be so low that it makes sense, and that taking on extra toxicities from combinatorial therapy, even for a fixed amount of time, may be less worthwhile. So I do think there is a real important balance as we're trying to develop these trials, because I do think many of the tools that are on the horizon that we're excited about are best served as fixed duration therapies. Bispecific T engagers are fantastic, but they're pretty immune suppressive, and you probably don't want to be using them for years on end. So how we harness a lot of these tools is going to intrinsically be in fixed duration ways. But I do think that in terms of our goals are lofty. Our goals for WM are cure, and I think towards that end really pinning down our approaches towards doing the best therapies for the shortest amount of times is a necessary component of that.
And Yazeed, from your perspective and your patients that you care for, how important is a fixed duration versus indefinite duration therapy?
Yeah, I think it's very important for a lot of patients. Although most patients will tolerate, for example, the BTK inhibitors really well, there could be these mild side effects like fatigue, for example, that could just come from the BTKI. And if we could combine the BTKI with another drug and potentially give it for a year or two instead of indefinitely, I think that's a huge plus for a lot of patients. It also opens the door for the possibility of using the BTKI again in the future. So if you give it, for example, for a year in combination with another drug and it works for 5 or 6 years, and then come back again, then you can try the BTKI again. And that, of course, can be a huge advantage as well.
Steve, perhaps I can ask you this question. It's a good one. Are some Waldenstroms patients being observed too long? So I guess this refers to the watch and wait population of patients. And maybe just to add to that is, do you think there's been a shift in sort of our thinking about introducing therapy earlier because the drugs are getting a bit safer in many respects?
Yes, a very good point. I think in years past, we only had very nasty chemotherapy that we needed to use. And so the whole goal was use it only when you really have to. And so many people, as I say, we would wait until there was substantial effects from the actual Waldenstroms before we would say, well, the effects from the chemo would be worth it. That really has changed because of the therapies that are now highly effective and much more modest in their side effect profile and better tolerated. It's interesting, I think, and many in the room might sort of think this through, is that sometimes there's like a badge of honor to say, I'm on a watchful waiting crusade and I'm not taking treatment. And there is actually a little bit of a risk that patients kind of stick with my protein is now sky high and I feel pretty much like death warmed over, but I'm sticking with this. And just to say, be cautious of that. I often say to patients, how close to the edge of the cliff do you wish to walk? Because in the past it was, we wanted to walk as close as we could. But to Steve's point, that's actually, I think, something that we can actually introduce treatment way sooner, because the goal of treatment is to start the therapy the day before you get symptoms. A little tricky to know when that is, but the idea is just when you get a sense that the disease is about to become something more symptomatic, initiating treatment, I think, has value. So I think the paradigm has changed a lot.
Yeah, Christian, would you agree with that? With the evolving therapies, we're moving the goalpost?
Absolutely. I think I completely agree. So the quality of, you should never, let's say, accept that the disease compromises your quality of life. So I think this is super important. Yeah, and as soon as you notice that your quality of life is compromised, it's the right time really to talk to your doctor, and probably you did this before, but then really to think about treatment. And we have a world-class expert on neuropathy here with Shirley, but particularly when you have neuropathy, because it's quite often not well reversible, we are very proactive in initiating treatment. So this is the one side. The other side is when you are completely asymptomatic, should you then start treatment? We don't have these trials, but again, we have very good trials from other related diseases like CLL. And there was a German study which randomized between, we don't call it watch and wait anymore, I was taught active surveillance, and ibrutinib in high-risk CLL. And the study was negative. So I think when you are really asymptomatic, the best therapy is no therapy.
Okay, there's another question here which I think is important for us to answer, and that is, how significant is the percentage of LPL infiltration in the bone marrow? And I guess sort of the pivot on this is, would that influence your decision to treat? And if so, what treatment you might choose? Jorge, you want to take this one?
Yeah, so there are a few issues about the bone marrow burden of disease. I think the important one is, does it really represent the amount of disease that the patient actually has? And we have seen situations in which the bone marrow burden of disease is relatively low and the patient has severe anemia. That means to me that probably they have more disease what the actually biopsy showed, or the other way around. We had patients with 80% disease in the marrows and their blood counts are beautiful, right? So I don't think we can use, or we should use, the bone marrow percentage of disease as totally face value to make decisions, and I typically don't do that. I do not believe that there's any data supporting a predictive value. So one thing is, to choose to treat, right? The other one is the predictive value of the bone marrow percentage of disease to tell me what treatment is going to work better, or how long a treatment is going to work, or how quickly the patient is going to respond. I don't think really there's no data to support using that percentage for chemotherapy or for BTK inhibitors or BCL2 inhibitors. So I particularly tend to use it for diagnostic purposes and to maybe see some evidence of progression or response to treatment. But I seldom, if almost never, use it to make treatment decisions and which type of treatment should I choose.
So this is also a very good question. I'll only get to the sort of summary of it, but it says that as patients we have heard the adage, you will not die from Waldenstroms, but with it. Can you help us sift through these conflicting messages? And I think maybe to sort of touch upon this, what are the other things you are telling your patients to be on the lookout for? Because You know, it's true, you're going to have Waldenstroms for a long time, but you don't want them to also not get screened for other cancers or take care of themselves in any other way that can also impact their longevity. Shirley, do you want to take this one?
So I think Waldenstrom does increase risk for a number of other conditions because of the immune suppression that comes with the disease. So some other, cancers such as skin cancers can happen. So I do encourage people to be looking out for anything unusual, and also to assess any symptoms that are not entirely in keeping with, say, the blood count. So if someone is extremely fatigued and they're not unduly anemic, I would look into checking their heart out, perhaps with an echocardiogram. I think also keeping fit and active is really important because even if you don't need treatment, if you do at some point, you will be physiologically fitter and weller to tolerate that treatment going forwards. Other things I say is, I encourage people to take the regular vaccines that are offered against the flu and COVID, etc. I know many people have concerns about that, but especially before treatment is needed, so that while you have more immunity, you'll mount a good response, hopefully, to that. So I think general attention to symptoms as a whole, keeping fit and active, I think these are important. And after treatment, being more aware that perhaps some risks are a bit greater, and also informing their family doctors that they've had these treatments, and not to put them in the same category as people who haven't had chemotherapy, or so to be just a bit more aware of the extra risks that potentially they might face.
Okay, super. Peter, this one's for you. Okay, what are WM experts doing today that future experts may say was wrong?
That's a good question. Oh my. You don't know. The hindsight thing can be kind of complicated. I mean, I think that's a really good, question. I think, obviously, we're getting, much more sophisticated in real time, and I do think we're practicing in a very, sort of, modern era. What are we doing wrong? I guess, we're learning as we go in terms of things like, thank you, in terms of things like, maybe targeting therapy. We just had that conversation about P53 and how we might approach molecularly divergent disease. We had talks this morning about, immune environments and how complex that is and how that may predict, so I do think that we may find that we have some tools that we can leverage that we're a little hesitant towards bringing into broad clinical practice right now, that we may look back and sort of wish we had adapted a little bit more aggressively around. We may also find that, we've learned this in some other diseases that, with certain therapeutics, immune supportive therapies are impactful in different ways. So, we may look back and sort of, wondered if we could have pushed these things a little bit more aggressively in those areas. Supportive care is a tough thing for us to study. We do a lot of therapeutic trials around new chemotherapies. We don't do as many around what we do for immune support and things like that. So we may find that some of those areas that have not been things we could evaluate as robustly may have benefited from some other approaches. But if I knew, I would be doing it. I would be telling you all the things that I do that are different than everybody else. So I don't know. It's tough.
Steve?
So just maybe a reflection on maybe the last 30 years, what we did do and what we've done differently that actually made a difference. I think Waldenstroms used to follow. We did what myeloma taught us, we did what lymphoma taught us, and then we stopped following and we started leading. And we started to see that if you actually do specific studies in Waldenstroms, you get answers that are unique to Waldenstroms and therapies that are specific for Waldenstroms. And I think that's made the biggest difference. So if I was to say, what do we need to keep doing moving forward, is lead, don't follow. recognize the uniqueness of this disease, manage and understand its specific needs and its specific biology. That's how we make progress.
Jorge, do you want to take this one too?
I mean, it's a challenging question, right? I mean, how do we know what are we doing wrong? I mean, we don't know what we don't know, right? That's typically the issue. So are we being too aggressive? Are we not being aggressive enough? Are we treating too early? Are we treating too late? I don't think we really know the answer to that question. But I think we all understand what the unmet needs are. I think we understand what the weaknesses of our research are. And I think, focusing on patient-reported outcomes, focusing specifically on quality of life, so understanding where there are some specific gaps that we can fill in, get to these deeper responses. I think none of that is totally wrong, but so I don't think we're doing something completely wrong. That's what I.
Yazeed, how about the final word on this question?
Yeah, so I think so in other types of slow-growing lymphoma, like follicular lymphoma, we just recently found out that we actually cure some patients. It just took us 20 or 25 years to recognize that. So maybe we're doing that actually for Waldenstroms. So maybe some patients are getting BR and then they're in remission for a very long period of time, but we still can't tell them they're cured because you need so long follow-up to say that. And so maybe in 5 or 10 years, we actually will be able to tell patients, we were actually able to cure you, we just didn't know that. That would be a great mistake to kind of recognize. And then we have a lot of tools right now that, I think we're just kind of combining the right drugs in the right ways for the right patients. I think maybe we have all what we need to cure patients. We just need to know how to use these tools in the right way. So maybe in 10 years, we'll say also, we actually had all the tools and now we can cure this percentage of patients. But we just didn't recognize that at the time.
Okay, so
Could I make
Shirley,
just
please.
one comment? I think something that's already happening now, I think, is that there's less time to spend with patients in clinics and listen to their story and their history. And so I kind of worry that this is going to get worse. So maybe we're doing it as best as we can now. And so looking back, I think in the future, maybe people have talked about AI a lot. I mean, maybe using tools for assimilating histories and investigations so that we can still focus on what patients are telling us will be, I think, something we must hang on to and not lose. Because whilst we are developing amazing therapies, which is fantastic, if you don't use the other hand, which is the clinical hand, then you're having a sort of one-handed clap. And I think you need to do both.
So maybe in future meetings, we'll have an AI here with us to give us the right answer. Okay, Christian, perhaps you could take this one. What are the options when a BTK inhibitor quits working? And maybe we should also talk about other BTK inhibitors that are being developed in this regard, and when you would sort of fit in those other BTK inhibitors, the second and third generation, as well as alternative therapies.
Yeah, so I think we are really in a very good situation that compared to just a few years ago, we have many treatment options when you develop resistance or you're not tolerating anymore covalent BTKI. So, of course, in theory, when you never have seen our chemo, you could go back to our chemo, but this would be probably not our preferred treatment option. So we would go you have non-covalent BTK inhibitors, pirtobrutinib, which is available in the US. It's not available in Europe, actually, because the company is not developing it for Waldenstroms, just for mantle cell and CLL, unfortunately. You have BTK degraders, so far still in clinical trials, but I think we anticipate that the BTK degraders will be approved for Waldenstroms. You have wonderful data from Jorge, from your venetoclax study, which we use a lot in Europe and in Germany for convincing our authorities to pay for venetoclax based on Jorge's trial with venetoclax single agent. Normally it's paid based on his publication. So you see, you have different options, of course. Always think about clinical trials. So everybody who is in relapse should always try perhaps to get information which clinical trials are running. So you see, it's a whole plethora of different options, and it's a situation where normally we can help you very well.
So one question that came up earlier, I think Jorge was addressing, was about mutation testing and whether one should be looking at BTK mutations as sort of a guide for, future therapies. Do any of you actually employ BTK mutation testing in your practice?
When we do a marrow at the point of relapse before starting any treatment, it does sometimes come up on our lymphoid panel. So I have sometimes seen it reported, but we haven't specifically asked for it. But when you do see it, it kind of does make sense when someone's progressing after a BTK. So it's kind of nice to know, but we haven't got it as part of our official panel.
And should we be incorporating BTK mutation testing after somebody, progresses on a BTK inhibitor? I think Yazeed was about to answer.
Yeah, so it's part of our panel at OSU. And I think sometimes certain mutations could predict resistance to pirtobrutinib as well. So that could potentially change your decision where you maybe prefer venetoclax, for example, over pirtobrutinib.
And I mean, now that the pirtobrutinib data has been finally published and all that, I wouldn't be surprised if a lot of community oncologists could use pirtobrutinib before they actually use covalent BTK inhibitors, right? And so the resistant mechanisms to non-covalent BTK inhibitors are actually a complete different set of BTK mutations, and some of them might actually impact, the covalent BTK inhibitors too. So I think at this time, I think we check them. I don't think I use them very much in terms of making decisions, but that might actually change if people start using non-covalent BTK inhibitors before covalent.
Super. Okay, in the last 7 minutes and 51 seconds, which gives you each about a minute to answer this, but it's a really important question, and that is, what message of hope would you leave patients with today? And Peter, can we start with you?
Yeah. I think, I'm hopeful that the whole meeting has felt very, very hopeful. I think it's really, I feel it in our clinic. I think it's never been a more exciting time to be somebody who is, with patients with WM on their journey and helping them through their treatment. Not only, getting better with the tools we have, but, all the things we've talked about in terms of what we know is coming, BTK degraders, next generation BCL2 inhibitors, T-cell directing therapies. These are things that are not just concepts. They're moving through testing in a way that they're going to be impactful tools for people who are living with WM now, over the course of their journey. So, it's while we are still sometimes in complex and difficult situations, we still deal, we'll talk a lot about how well we do across most patients, but that still leaves some folks dealing with pretty difficult circumstances. We're doing better and better at hopefully finding the right tools for even those situations. So, it's hard not to see how positive and hopeful the landscape is.
Shirley?
I think for me, the biggest source of hope are the people involved. We have a wonderful WM community of doctors and patients, and I think it always warms my heart when we have these sort of gatherings. We had one in Athens recently. It's just the working together that for me is the most hopeful thing.
Steve?
I think this morning we saw the curves which said, in the world of myeloma, the disease has gone from devastating to now curative in a subset of patients. I think we can say the same is true in Waldenstroms, where it went from, when we started, a very poor outcome disease with not a lot of disease treating tools and not a lot of understanding of biology, to a fundamentally different circumstance where you just heard from Christian a plethora of options. And we discussed earlier, you were just saying, maybe we're going to identify that curative group. So if we were to say, if we looked back over 25, 30 years and see the progress and just see how it continues to accelerate at that pace of change, we should be there where most patients can be potentially cured. in a not very distant future.
Christian, what's your message of hope?
Yeah, so I would have said really more or less the same. I think the biggest source of hope is, actually it's not hope, it's a fact that we already today achieve functional cure in most of you. And I think the hope is, and it's so realistic, it's not really a hope, it's more that the proportion of patients being functionally cured will increase dramatically. I think it's not a linear curve, but it's an exponential curve because of the progress we have. Of course, then we have still the fact of being biologically cured, but when you see all this, and I think myeloma, it's an amazing example. So I remember, and I'm not 150 years old, how the myeloma patients, what they were when I was a young resident. Yeah, so it was really devastating also to experience this. And when we see how this developed in myeloma, you can take mantle cell lymphoma, so many examples. So the fact is, functional cure is there. The hope is we will increase the proportion of you dramatically. And I think it's a realistic hope that also biologically we can at some time point eradicate the disease.
Jorge?
Yeah, so at the Dana-Farber, we have a large clinic, as you all know, and we look at our data, every year. And for the 13 years that I've been at Dana-Farber running, the clinic along with Steve and the rest of my colleagues, I've seen the outcomes of these patients, and I've seen the median overall survival doubling over the last 10 years. The number of people dying from Waldenstroms decreasing dramatically. 5 or 6 new treatments in the last 12 years for Waldenstroms already approved and available for patients. So this is something I've seen. And I do believe that that is not stopping. I don't think we have gotten to a plateau situation. I think the survival will continue improving. I think the dying from Waldenstroms will continue decreasing. The number of options will increase based on the trials that we have seen and the future trials that are being planned. So there are so many reasons, I believe, to be very optimistic about this.
Yazeed, you get the final word.
Yeah, I think the future is bright. I think we already have great tools, great treatment options, and we only expect more to come. Hopefully more effective, safer, and again, hopefully time limited. So a lot of reasons to be hopeful about the future for our patients.
Yeah, I have to also agree. I don't think in the 30 plus years that I've been working in the Waldenstroms field, I've been more optimistic about finding a cure for this disease. And if you were also there at the conference on cellular therapies, you'd be really also inspired by what has been accomplished in the other collateral diseases. Multiple myeloma, which people used to look at as a far worse disease than Waldenstroms, and here we are today seeing functional cures and even realistic cures being defined. And so I think that is the message of hope. But I want to say the IWMF has been behind all these innovations, and we're so grateful to you for being able to provide the support that's going to keep us going and get us to a cure. And with that, I just want to thank our panel members for making their time available, for coming all the way to Columbus, Ohio. Yazeed, you didn't have to drive too far. But Shirley came all the way from the United Kingdom. Christian came all the way from Germany. Steve, your journey was also, a few hours to get to us from the Mayo. Peter, you came to us all the way from Denver, and Jorge all the way from Boston. So let's give our panel a round of applause.